Starting with our next session, I would like to call, that is orientation session. I would like to call upon the stage for our next chairperson, sir, and ma'am, Dr. Smita ma'am, Dr. Anbar Dey, sir. Please, sir. Also, for the next presentation, I would love to call upon the stage Dr. Swaraj, sir, who has been actively contributing to diabetics management and clinical medicine. Through his dedication to patient care and research, Dr. Swaraj continues to contribute meaningfully to the medical community. Please welcome, sir.
At the outset, I'd like to thank the organizers for giving me this wonderful opportunity to have this Professor Akira oration. Professor Akira was a Japanese biochemist who is named as the father of statins. So the amount of statins that we are using in our current practice, I think I owe to him. Since I am in the cradle of the knowledge and it's postprandial and everybody are a little low, so I think it would be prudent that I invoke upon Lord Shiva. Can somebody repeat after me? Namo Parvati Pate Har Har Mahadev. I think this definitely sets the mood in a very comfortable way so that we can progress in the next 10 to 12 minutes about future of integrated CKM care, how this integration is going to help us in our clinical practice so that we can take better clinical decisions and better patient outcomes. I am Dr. Swaraj Waddankeri from the land of Kalaburgi. That basically means that the land is filled with a lot of stones. Here in Kashi they say Kankar, Kankar, Shankar, Shankar. So I also come from a different sort of Kankar. So there is some sort of connectivity. So CKM syndrome paradigm, the interlinked pathophysiology. I think Dr. Sandeep Suri in the morning gave a very, very nice oration in the morning where he said that when one organ is affected, the other organ may or may not be affected, but there is definitely some amount of subclinical disease that is already happening within the body. So when I talk about, or when I say about diabetic kidney disease, that doesn't mean that only the kidney is affected. There is a myriad of other organs which may or may not be affected. When I say may not be affected, that basically means that I have not clinically checked it. I have not gone out and looked for it. It is there, but we are not seeing. So this is where this integrated pathophysiology, understanding the integration of the CKM care in our day-to-day clinical practice forms a very important shift in the clinical practice. So when I was doing my post-graduation, how we used to treat diabetes versus how I am as a clinician seeing diabetes, there's an entirely sea change. So why this CKM integration now? There is a converging burden of cardiovascular, kidney and metabolic disease. This epidemiology and competing risk factors, the renal paradox. Most patients with diabetic kidney disease, this is a very funny anecdote. Diabetic kidney disease patients die of cardiovascular disease or heart failure before reaching end-stage renal disease. So if you are 3A or 3B, you are more likely to die before you reach the stage 5 of kidney disease. So CKD 3A, 3B is a very high risk for cardiovascular disease and not for the renal disease. So if you are having CKD 3A, CKD 3B, you are at more risk of having a target organ from kidney goes to the heart. So we are not looking at just the kidney. So when I say that there is CKD 3A or 3B, there is already the heart which is at very, very grave risk. So this is why this integration is very, very important to us in our clinical practice, where there is a interlocked biology. The metabolic, renal, CV pathways are not distinct. We say that, okay, fine, a patient with an ST elevation MI, put a stent over. No, it is not going to happen like that. That stent, whichever we are putting, is just like a paracetamol for the fever. What are we doing for the underlying pathophysiology? We are not doing anything much. So that is where this integration is very, very important and clinically imperative. So how does it help? It unifies the prevention and therapy. It develops a team-based approach. As I think many of the speakers earlier also spoke about, gastroenterologists will see this, the orthopedicians will see this, the renal will see this. So this concept has to go wherein all of that has to come together for the better patient care. So what are the new tools that we have? Of these new tools that we have, Multi-Omics and AI are for earlier detection before traditional albuminuria or EGFR go and increase. So I think this slide has been shown n number of times since the morning that I've been here from 10:30. So progression is driven by a confluence of metabolic toxicity. So when I say metabolic toxicity, it is just not about diabetes, it is just not about hypertension, it is just not about your albuminuria, it is just not about your retinopathy. So there is something that pro-inflammatory state which diabetes sets up, that is very, very important to address. So this is about one thing. Then there is a hemodynamic strain. There is glomerular hyperfiltration and there is maladaptive immune response. This is very important. When there is maladaptation at the cellular level, there is a body's compensatory mechanism that kicks in. So when the body's compensatory mechanism kicks in, there is adaptive response, a maladaptive response. Adaptive response, yes, there is an insult at the cellular level. The cells try to fight it and then they win. And then that story ends there. But when there is an insult to the cell, the body fights and then it tries to adapt, tries and fails. And then what happens? That one maladaptive cell becomes a confluence of a site wherein all the maladaptive cells come together and lead to the beginning of the inflammation cascade, leading to the toxicity or in the toxic or the target organ damage. So we all know this. Diabetes only, the risk is lower. Diabetes plus CKD, the risk is a little higher. Diabetes plus CVD, the risk is higher. But when I put all three together, the risk is definitely far more higher. So we all know people with diabetes, there are a number of theories which suggest that if you are diabetic, you are equivalent to a already existing heart disease patient. So that is very, very important to understand that only one is not going to help us. We have to look at 4 or 5 things together so that we make a very, very good approach to the patient and have a better clinical outcome. So the CKM screening patient strategy by stage, I think universal stage 1, stage 2, everybody has spoken the same thing. But for us to understand this very important thing is at stage 1 when there is a metabolic syndrome components every 2 years. But I think in the Indian context it can be as low as every 6 months. FIB score probably every year based on the risk the patient that we are seeing. USCR plus EGFR, this is what we commonly do in our routine practice. This is annually minimum. So minimum matlab the basic. So if we are catering to patients with diabetes or people with diabetes, this is the minimum that we could do. But if we are into specialty practice, only minimum is not going to help us. So we have to be cut above the rest. So we have to do something more. So that is where this comprehensive metabolic or the KDIGO heat map, I'll probably talk about it. And then when we have a subclinical atherosclerotic vascular disease, we have to look into CSE scores, NT-proBNP levels and echocardiogram if indicated. So the current standard versus the next gen precision. How is this going to help us? So what is the current standard? The current standard is limited functional markers, EGFR plus albuminuria. If there is non-albumuric DKD, significant proportion of the patients progress to end-stage kidney disease without ever having to develop macroalbuminuria. So you are doing the screening but you are not getting anything and you have left it. So this leads to, when the patient is having a non-diabetic kidney disease, leads to progression into NDKD or the non-diabetic kidney disease, wherein we have not looked at looked at the CKM component at all. Then there is a black box pathology wherein the kidney biopsy is suggested, but the cost is quite huge. If I look at the cost, at least in my place, the nephrologist charge somewhere in between 20 to 30,000, and I am talking of a tier 2 city. I don't know if it is probably 60,000 or more in a tier 1 city. So, and plus the amount, the technique in which the biopsy is done, what is the amount of kidney tissue that or the renal tissue that has come, and how good the pathologist in that area. So it is a very challenging situation. So how can we overcome with this single cell resolution mechanistic phenotyping, wherein this transcription maps specific, it maps the specific cell types, the maladaptive proximal tubules. They are called as IPT or MPT. So these are liquid biopsy omics, where proteomics and metabolomics detect early mitochondrial dysfunction and inflammatory signatures in urine and plasma. It is just as good as giving a simple blood sample. So you take a blood sample, you look for it. So probably 15 years or 10 years before, when I started my practice, the very, very small HbA1c monitors, we all used to question them. Now after 10 years, US FDA has given clearance to quite a lot of this inverted commas POCT, point of care devices, wherein the patient comes, you draw a blood sample, put it, report is ready in 10 to 15 minutes. So no centrifugation of the sample is also not required, just a small blood sample and you are done with it. So are we heading towards it? Probably Jitendra Singh, the union minister, had said the same thing. India is at the cusp of adopting what is called as precision medicine. This is also a part of the precision medicine, wherein we integrate the patient's clinical data, the laboratory data and the genomic data, so that we can have a attempt to reduce the mortality, morbidity and give a better quality of life to the people who are living with diabetes. See, this is the technology overview. I think over a period of time we will be far more adept in understanding this. I'll just I'm sorry. I'll just talk on the right hand side. So what is bulk omics, single cell omics and spatial omics? So bulk omics is average expression of the tissue homogenate, that is a fruit smoothie, wherein you have put multiple fruits and you have then made a smoothie, so you don't know what it is, what is not. So then you have a single cell, wherein you profile individual cells, and then it is where heterogeneity is revealed. We have been hearing since morning that diabetes is not a single disease, it is a heterogeneous disease. No two people with diabetes will have a similar presentation, no two people with similar glycemia will have same target organ damage. One person with diabetes of 30 years with no microvascular damage, whereas a person with 3 years of diabetes has come to you with a end stage renal disease, or has come to you with a creatinine of 4 or 5 with sugars of 500 diagnosis. The disease remains the same, but how it presents to us is the heterogeneity, and this is where this single cell omics can help us identify this different type of kind of presentation, so that we are very adept in handling how things are going to progress. So one thing very important for us to understand is we should be able to predict what is going to happen. Only when we know what is going to happen, we will be that much more serious in telling the patient. So the sugars are 300, 400, and if you are not giving insulin, we know what is going to happen. Patient, whether he wishes to take or not to take, that's a different scenario altogether. But we know what is going to happen in the next 5 years. Today, patient refused insulin, you will write in your case sheet, patient refused insulin. Patient comes 6 months later, sugars are from 300 have gone to 400, patient refused insulin. But at the end of 4 years, we know what is going to happen. He will end up either in a retinopathy or a DKD, or will have an MI. It may or may not be silent. So this is where when we know, when we do, then we know, and then we act. So that is what is the whole concept of this multi-omics technology. So spatial omics, wherein the expression is mapped to tissue location, microenvironment context. The context is decided, as I was talking about the maladaptiveness. So when we know that the maladaptive cascade is about to set, is set or is going to set. When we know is going to set, we will be acting. So when we are acting when the maladaptive response is going to set, so the outcomes will definitely be 100 times far better than what it is. So
Dr.
this is
Swaraj,
the healthy.
Dr. Swaraj, I've got strict instructions from the chairperson that we should stick to time. So if you could summarize
so
and
this
conclude.
is quite a lot of my matter, because they had given me the topic. So quite a lot of physiology and understanding of basic things. So integrative multi-omics framework, I think sample input, high resolution profiling, that is where we do this the sRNA sequencing, then we integrate it into a specific data set, then look at the context, and then the clinical output. So this gives a precision diagnosis. So the 4 pillars which guide our therapy, I think we have been using RAS inhibitors and ARBs since the past 20 years. So that forms the first pillar. Second is SGLT2 inhibitors. Third is GLP receptor analogs. Why we use it is all at the bottom, because we have n number of clinical trials which tells us how best we can use it for a good patient outcome. And then we have the last one, or the latest kid in the box, the Fenrinon. The key clinical trial that was involved was the Fidelio DKD and the Figaro DKD. So all these 4 things address 4 different pathophysiological or 4 different pathophysiology. That is where we have to make sure that the patient is either on 1 or 2 or a combination of more than 2, depending on the patient's profile. So combination therapy, what are the lifetime benefits? As you can see, there is a significant reduction in MACE, heart failure hospitalization, CKD progression, CV death and all-cause mortality. So the 5-point MACE is significantly reduced when either used in isolation or in combination over the next 2 to 5 years. So projected gain in event-free survival, as you can see on the right-hand side, we are able to give a good quality of life to the patients. So when there is a synergy between SGLT2 inhibitors, when we are using SGLT2 inhibitors and GLP-1 receptor analogs, there is a decreased 3-point MACE, that is decreased CV death, decreased all-cause mortality and decreased MACE. So adding finerenone, it targets the residual risk. It has a consistent additive effect, whereas it has a good safety and mitigation. Of course, hyperkalemia is the one very important thing that we have to look into. First at 15 days, then at 1 month, and then at 2 months, potassium and creatinine needs to be monitored. So how do we implement this in our practice? Key barriers: therapeutic inertia. If I don't know, I will not do it. So first is I should know, I should educate my peers, I should educate the people who are involved in the care of people with diabetes. That is when it is going to happen. Cost and access. The cost of the HbA1c machines earlier was close to 15 lakhs. Now the FDA approved devices come at 1.5 to 2 lakhs. So that is over a period of time it will definitely change. The fragmented care should change, and the polypharmacy, the burden, medication burden leads to reduced adherence. So when we are combining this, the risk of disease progression decreases, patient adherence increases. That is how we have to look into it. Then what are the system enablers? Team-based clinics. So CKM clinics, of course, this in a private setup becomes a little of a problem, but in an academic institution, definitely team-based clinics wherein you can have CKM clinics. Protocolized care wherein automated EMR prompts for USER screening and algorithm prescribing are taken into consideration. Shared decision making, rather than one person making a decision, a shared decision making can be taken. So beyond the pillars, I think I will probably have a discussion offline. Yes, this is the core message. CKM lens is essential. Whenever I look at a patient with diabetes and kidney disease, it is just not about the kidney. We'll have to look at the liver, we'll have to look at the brain, we'll have to look at the gut, we'll have to look at the heart. So that is very, very important to understand. So UACR and EGFR are the simplest things. Start SGLT2 inhibitors, optimize your ACE inhibitors and ARBs to BP of less than 130/80. Add finerenone, make sure that the ACR is more than 30 and with a normal potassium. Continue or initiate GLP, looking at the residual risk, and refer to a nephrologist only when all your efforts have failed. If you are referring a patient to a nephrologist who doesn't require dialysis, I think we are failing. Thank you.
Thank you very much for that fascinating talk on cutting-edge omics. In the interest of time, could you please ask Dr. Swaraj? I'm sure he'll be willing to entertain your questions over tea, if that's okay. In the interest of time.
Yes.
Okay.
Sure. Thank you.
Thank you, Dr. Swaraj. Dr. Yasmeen Syed.